My name is Judith Anderson, and this is a presentation on smoking and acute myocardial infarction in adults. The exposure of interest is smoking cigarettes. In 2014, 16.8% of adults in the United States 18 years of age or older smoked cigarettes. In Kansas in particular, 18.1% of adults reported smoking cigarettes. Smoking is also the leading cause of preventable disease and death in the United States, with more than 480,000 deaths every year in the U.S. attributed to smoking. More than 1 in 3 cardiovascular deaths worldwide can also be attributed to smoking. The total economic cost of smoking is more than $300 billion per year for the United States. This breaks down into nearly $170 billion in direct medical costs and more than $156 billion in lost productivity due to premature death and exposure to secondhand smoke. The outcome of interest is a myocardial infarction, also known by many people as a heart attack. Every 43 seconds, someone in the United States has a myocardial infarction. Around 15% of those who experience a myocardial infarction will ultimately die from the event. The estimated annual cost of cardiovascular disease and stroke is $320 billion. This breaks down into around $195 billion in direct medical costs and $124.5 billion in indirect costs from lost future productivity. Even more concerning is that by 2030, these numbers are expected to rise to around $818 billion in direct medical costs and $275 billion in lost productivity. Improving cardiovascular health is also a Healthy People 2020 goal, specifically improving cardiovascular health and quality of life through prevention, detection, and treatment of risk factors for heart attack and stroke, such as smoking. We will now look at 3 studies that evaluate cigarette smoking and the outcome of an acute myocardial infarction. The first study is a prospective cohort study that was initiated in 1967 and ended on December 31st of 1995. The study contained 9,681 women and 8,888 men 34 to 83 years of age from Reykjavik, Iceland, and adjacent communities that were selected from a national roster. The exposure smoking cigarettes was measured using self-report, and the smokers were ultimately divided into 3 groups based on the number of cigarettes smoked per day. The outcome of interest and endpoint of the study was either a non-fatal myocardial infarction or death due to coronary heart disease. Non-fatal myocardial infarction was measured or identified using the Monica criteria. The Monica criteria defines a definite myocardial infarction as one that is either definite on an electrocardiogram when a patient who has symptoms of a myocardial infarction with probable changes on an electrocardiogram and abnormal cardiac enzymes, or a patient with symptoms of an acute myocardial infarction with abnormal cardiac enzymes. Death due to coronary heart disease was measured based on the underlying cause of death on a death certificate. The causes of death that were included were those classified as International Classification of Disease 9th edition codes 410 to 414.9. The strengths of the study include the prospective cohort design, as this can allow us to be sure of temporality. The study population was also a strength, as this was a large population-based cohort with 99% follow-up. The researchers also adjusted for multiple confounders that are known risk factors for myocardial infarction, including age, blood pressure, cholesterol, triglycerides, diabetes, and body mass index. The main weaknesses in the study were related to the potential for misclassification bias. Smoking cigarettes was only evaluated at the beginning of the study, and as this was a 28-year follow-up, participants could have stopped smoking or altered their smoking habits during the follow-up period, resulting in them being inappropriately classified. In addition, smoking cigarettes was reported via self-report, which leaves open the possibility that participants were not truthful in reporting their smoking habits. Identifying the outcome of death due to coronary heart disease is difficult, as death certificates could be coded incorrectly, also leading to misclassification. Selection bias may have also been a problem, as participants were required to attend 2 examinations in person. This could ultimately exclude those participants who are too unhealthy to attend and/or homebound. The second study is a case control study containing participants that lived in Costa Rica from 1994 to 2004. Cases consisted of 1,543 men and 551 women who were survivors of a first acute myocardial infarction recruited from 6 hospitals in the Central Valley of Costa Rica. Controls were randomly selected from the National Census and Statistics Bureau of Costa Rica and were matched to cases by age plus or minus 5 years, sex, and area of residence. The exposure of smoking cigarettes was measured during an at-home interview using a standard questionnaire. The questions on the questionnaire included current smoking status, duration of smoking, and age when smoking started. The outcome of a non-fatal acute myocardial infarction was measured using the World Health Organization's criteria for an acute myocardial infarction. This is defined as typical symptoms of a myocardial infarction plus elevation in cardiac enzymes such as the troponin or CKMB mentioned earlier, or changes in an electrocardiogram. In addition, cases were identified by diagnosis by 2 independent cardiologists. There were several strengths in this study. The first strength is how the controls were selected, as they were selected at random from the national census and matched to the controls. The use of incident cases was also a strength of this study, as cases with previous myocardial infarctions were excluded. The results of the study were also adjusted for major risk factors for cardiovascular disease to prevent confounding. This includes obesity, diabetes, hypertension, and high cholesterol. There were also several weaknesses in the study to include selection bias, as cases were selected from 6 hospitals and only included those who did not die from a myocardial infarction. Therefore, they may not be truly representative of the population. Recall bias may have also been an issue, as 73% of cases were interviewed in the 2 weeks following their incident. However, this may have been too long for optimal recall. Interviewer bias may also have been an issue, as interviews were conducted at the home using a questionnaire. However, the interviewers may have altered their methods of interviewing or have been more aggressive in assessing smoking exposure in those they knew to be cases instead of controls. Study 3 is a prospective cohort study initiated between 1994 and 1995 with an 11-year follow-up. All residents in Tromsø, Norway, born before 1970 were invited to attend. The study ultimately contained 11,762 men and 13,206 women from Tromsø, Norway. The exposure of smoking cigarettes was measured using a self-report questionnaire filled out at the beginning of the study. Smokers were divided into 3 categories based on the number of cigarettes smoked per day. Although the authors evaluated both passive and active smoking in the study, the exposures were separated, therefore only active smoking exposure information is used here. The outcome of a myocardial infarction was measured using 2 methods. Hospitalized cases were identified by linking the study participant list to the discharge diagnosis register at the University Hospital of North Norway. The criteria used to verify a diagnosis of a myocardial infarction was the World Health Organization Monica-Morgam criteria discussed briefly earlier. Records were also retrieved to further ensure that patients met criteria. The study participant list was also linked to the nationwide causes of death registry at Statistics Norway. Death certificates were retrieved for participants with underlying diagnosis of cardiovascular disease or sudden unexpected death. Autopsy reports were also retrieved for further evaluation when possible. The strengths of the study include the prospective cohort design, as this allows us to be sure of temporality. The study population was large, which is also a strength, as it included 24,968 participants. The identification and inclusion of both fatal and non-fatal myocardial infarctions is also a strength, as this allows for a more realistic reflection of the population. Misclassification bias was a likely weakness in this study, as cigarette smoking was only evaluated at the beginning of the study, allowing for participants to have altered their smoking habits or stopped smoking during the follow-up period, resulting in them being inappropriately classified in the study. There's also a potential for misclassification due to the use of a self-report questionnaire, as participants may not have been truthful regarding their smoking habits. The use of death certificates when classifying patients' cause of death may also lead to misdiagnosis and therefore misclassification. Selection bias, as with the previous prospective cohort study, may also have been an issue, as participants were required to attend a physical examination in person, which ultimately excludes those who were too unhealthy to attend and or homebound. Provided here are the results of all 3 studies. You will note that all 3 studies found a dose-dependent increase in risk or odds of myocardial infarction with smoking cigarettes. In addition, all 3 studies also found an increase in the risk of myocardial infarction in women who smoke as compared to men who smoke. You may notice that the odds ratio for women who smoke greater than or equal to 25 cigarettes per day, and study 2 is not provided. This is due to the fact that there were not enough women in the study who smoked greater than or equal to 25 cigarettes per day to calculate an odds ratio. Provided here is a comparison of all 3 studies using the Henneken's criteria. You will note that all 3 studies had results that were statistically significant. In addition, all 3 studies were at risk for selection bias, and 2 of the 3 studies were at risk for misclassification bias. All 3 studies controlled for possible confounders that were major risk factors for myocardial infarction, to include blood pressure, cholesterol, and obesity. Although study 2 did not control for body mass index, waist to hip ratio was controlled for. 2 of the 3 studies also controlled for other risk factors for myocardial infarction, to include age, diabetes, and amount of physical activity. The strength of association between smoking cigarettes and the risk of an acute myocardial infarction was moderate to strong across all 3 studies, with 2 exceptions. The first exception is in study 2 with the odds ratio of a myocardial infarction in men who smoke less than 15 cigarettes per day, as this was a weak association. The second exception is in study 3 with the risk of a myocardial infarction in men who smoke less than 10 cigarettes per day, as this was also a weak association. You will also note that the strength of association increases as the number of cigarettes per day increases. Biological plausibility was there for all 3 studies, and all 3 studies were consistent. Temporality is also there for all 3 studies, and all 3 studies noted a dose-dependent response, as discussed previously. In conclusion, research suggests that smoking cigarettes significantly increases the risk of an acute myocardial infarction. However, additional research is needed regarding the elevated risk of myocardial infarction in female smokers as compared to male smokers. The impact of smoking cessation on the risk of myocardial infarction should also be evaluated, in addition to research on the risk of myocardial infarction with other forms of nicotine inhalants, such as e-cigarettes, pipes, and cigars. Healthcare providers should ultimately screen every patient for tobacco use at every appointment, and smoking cessation treatment should be offered to all participants who smoke. Anti-smoking campaigns should be developed that are geared towards women. We have anti-smoking campaigns geared towards adolescents and anti-smoking campaigns geared towards all smokers. However, given the results of these studies and the increased risk in women, anti-smoking campaigns geared toward this population should be considered. This concludes the presentation. Thank you for watching, and the next 2 slides are a list of the references used for the presentation. Thank you.